Well, hello and welcome again to episode 11 of RTMatters, a place where candid conversations take place about what matters most to respiratory therapists. I'm Patrick Dunn, your host, and I'm delighted to welcome you to our podcast. Now, before we begin this episode, a few housekeeping details to attend to, especially for our first-time listeners. First, all episodes, today's as well as all prior episodes, are available through your favorite podcast app. Open access, no charge, no subscription fee, no membership required. And second, we welcome your feedback. That's right, we want to hear from you, our RT listeners. Thoughts about this particular episode, prior episodes. That's right, we want to hear from you. And also at the same time, tell us what really matters to you so that we know going forward how we can reach your expectations. You can email us directly by hitting the link feedback@rtmatters.com in the description right before this episode. And at the same time, I want you to know that RT Matters is a virtual voice for respiratory therapists everywhere. So please let your fellow RTs know about this timely new resource. Now on to this episode. Be careful what you wish for. Delegating so-called routine basic respiratory services to non-RTs. Our guest panelist today, and I'm really delighted to invite her, is Carri McClure. She is a clinical supervisor of respiratory care. She's a registered respiratory therapist. We'll talk more about her academic background in a moment. But she's clinical supervisor of respiratory care at WellStar North Fulton Hospital in Roswell, Georgia. Welcome to RT Matters, Carri.
Thank you for having me. I'm excited to be here.
Well, we're getting to know you very well because I want to disclose later on that we first started talking last March when I read one of your posts on Instagram, and we'll get to that in a moment. But one of the features of RT Matters is to have our guests share with us how you first learned about respiratory therapy, where you were when you first decided to become an RT. The question is, did RT find you or did you find RT?
Well, kind of both, actually. So you might have read about this on LinkedIn, but 3 days after I was born, my mother had Guillain-Barré syndrome and had a tracheostomy tube and was on a ventilator and hospitalized for about 8 months. And of course, I don't remember that because I was an infant. But, I grew up hearing those stories, hearing about, her journey through, recovering from Guillain-Barré. And, fast forward, later on in life, I became a mom and my son was actually born with Pierre-Robin sequence and a partial cleft palate. So he spent a good deal of time at the Children's Hospital. And so I was exposed to respiratory there. And caring for him, I realized, well, gosh, if I can do this with my own child, maybe I could do this, as a career. And so I thought initially I wanted to be a nurse. And I shadowed a friend of mine and didn't like it. It was not for me. I was more interested in where the respiratory therapist was going, what they were doing. I saw them.
Really funny that you mentioned that because most of the people that we interview, they all say the same thing. They either saw a respiratory therapist by a family member being treated. Several EMTs watch the respiratory therapist in the emergency department.
Yeah.
So the board is always watch how you practice because you never know who you might influence to become one of respiratory therapists.
Exactly. And that was kind of the moment for me that I was like, gosh, I don't think I want to be a nurse. And, a friend of mine, we were actually supposed to go into the nursing program together. And she is also a respiratory therapist. She was like, this is not for me either. So it was funny. She kind of helped me find my way into that. And, and I just loved it. I've loved it ever since.
Right. Well, now you obtained your bachelor's degree in respiratory therapy from Dalton State College in 2016. That was actually a new program back in the day.
Yes.
But you didn't stop there. You returned and obtained your master's in business administration from the prestigious Terry College of Business at the University of Georgia. So the question is, looking back, what prompted you to continue your education after you already retained your registry and your BSRT degree?
So I was fortunate enough to be nominated to attend WellStar Leadership Academy. It's a kind of a leadership development program that WellStar does through Kennesaw State College. here in Georgia. And it's only a 6-month program, but it was really a life-changing experience for me because it really made my thinking a lot more strategic, I guess. Of course, it was a very brief overview. It was a 6-month program. But during that time, I got to learn about change management and, leading evolving organizations and, some of the more fine details to the leadership part of things. And, after that, I knew that I wanted to get an advanced education. I just wasn't really sure which direction I wanted to go.
The light bulb went off, right? The light bulb went off.
Absolutely did. And so one day after an administrative huddle, I was talking to the CFO. He probably doesn't even remember this conversation. But, I was telling him I wanted to do something. I didn't really know, which direction I wanted to go. And he said to me, Carri, the clinical side of healthcare. What you need to know now is the business side, because if you can speak both languages, you will be unstoppable.
Great mentor. Interesting. Along those lines, there's a letter to the editor in November issue of Respiratory Care by Dr. Jithan Niz. I'm going to read around. He's unique. He's the first PhD in respiratory therapy. Issued at a university in India. He's now working in Canada. And in this letter to the editor, he's talking about all the barriers for people who want to get an advanced degree, whether it's in respiratory therapy or in your case in business. And he said one of the biggest pushbacks, aside from the time commitment, the financing, was that there was a widely held perspective that there's no immediate compensation at the end of your process. Why don't you address that, if you would?
So that's a really interesting point. And that was something that I heard a lot even when I was going back to get my bachelor's degree. Everybody's like, well, you don't really need it. I mean, you're not going to get paid anymore. And I'm like, well, no, but I'm going to have more options. So, one day I'm going to be older and it's going to be hard to be pushing vents and lifting patients and doing all of those things. And so, I at least have an opportunity or an option of doing something else. So that's what motivated me.
Yeah. The point is you really want to take advantage of your younger years and prepare yourself for what will be the future, which we don't know. But why not? Why waste your time? Why waste your time? Well, now let's take a few minutes and have you tell us a little bit about what a typical day for you looks like, or probably day and night at WellStar, your current position.
Oh, gosh. No day is typical for sure. But, some days, I come in. Usually I review any safety reports that, have come over from the day before, any support staff issues. I investigate process failures, any staffing concerns. Mm-hmm. I sit on a lot of committees. I'm on the Critical Care Council Committee, Code Blue Committee, Pressure Injury Prevention, Patient Experience. I'm on the daily throughput.
One could really say that you have just as much of an impact, if not more of an impact, on patient safety and patient outcomes, because you're involved in so many more dimensions that the bedside clinician probably doesn't realize impacts their ability to provide excellent patient care.
Absolutely. We need to be involved in all of those conversations. And so I'm very fortunate that my boss, even in a supervisory position, has allowed me the reach that she does. She's really tried to grow and develop me as a leader. And so she trusts me to represent our department in all of these different spaces. And, I also round on patients for voice of a customer and help, which is interesting because I get to be at the bedside with the customer to hear what kind of, experience they're having. The daily calls that I'm exposed to for discharging patients, I get a front row seat to seeing what barriers are to discharging.
I'm assuming you're just a great role model for a lot of people in your department and other parts of the hospital as well. Well, let's turn our attention to this particular topic because I know this is a big part of your fatigue. And that is basically in March 2025, you made a post to LinkedIn, which is where I first saw you. Mm-hmm. And your post was, you can't have it both ways. And what you basically took strong exception to this concept of delegating to other disciplines, what you called fundamental tasks. And you specifically mentioned administering an MDI or NEB treatment. Mm-hmm. What motivated you to compose this very detailed, and I might add, very passionate post?
Well, honestly, I mean, both frustration and heartbreak. I kept seeing on social media and some of the respiratory forums that, respiratory wants more respect, more pay. But they also wanted to give away the fundamentals of what our role is. And, bedside assessment and education and technique, I mean, that's where our value is. Our value is in the assessments that we perform. So that's really where that was born from. I was really frustrated and disillusioned because that just didn't make sense to me. You can't.
What type of response? What type of response did it generate? I don't know if you received a lot of feedback. I didn't see much on LinkedIn except positive vibes, but I'm sure other people probably shared some thoughts with you.
So LinkedIn was overwhelmingly positive. I did find out that I made it to Reddit, which the response was not necessarily as positive. But that tells me that it hit a nerve and it was a conversation that needed to be had. I think some of the response was that I was uninformed about the realities of healthcare. And I understand that. I lead people that live those realities and I've lived them myself. So I understand. But if we become visible there, we become visible everywhere.
Yeah, I think we're going to drill down more on that because some new developments have occurred since that. Why do you think some of our RT colleagues might support this? I often hear, well, they're only NEB treatments, for God's sakes. Mm-hmm. What do you see? I mean, what's the long-term professional consequences if this trend gains momentum?
I mean, this just could really devastate our career. I mean, and any advanced practice, respiratory therapy programs moving forward, there's a lot of momentum there. So, anytime you have to give a breathing treatment or, an inhaler, that requires assessment. So, the fact that, we're saying that, these things are tasks and don't require any kind of assessment, that's just flawed.
I actually, on my own initiative, and I'm pushing this, I don't like the word treatment, NEB treatments. I like the word therapy sessions. And it might be bronchodilator therapy, it might be airway clearance therapy, it might be ventilator weaning therapy, ventilator liberation. I don't like this treatment stuff. I like what our physical therapists do, is a therapy session.
Yeah, and that's very true.
Now, coincidentally, in October of 2025, I think I lit another fuse under you. Breathing Matters, which is a newsletter of the Respiratory Care Licensing Board of California, sought to, and I'm going to quote this directly, they wanted to provide a clearly defined framework distinguishing between basic respiratory tasks that may be delegated to and performed by non-RT staff by drawing a clear line between routine basic tasks and complex clinical services. I want to point out that both you and I took polite exception to what that we're doing. The delegated tasks that they indicated would be pulse oximetry, medication administration without a ventilator adjustment, and tracheostomy hygiene care. The document also states, and this is to your point, any service requiring assessment or evaluation remain the exclusive responsibility of the respiratory therapist. Let me just ask you, and I'm being a devil's advocate, what RT services come to your mind that do not require assessment or evaluation?
Well, none. Because if you have to touch a patient, you have to assess a patient. And, I understand that, I'm sure this was well-meaning, but, you're making clinical judgments the whole entire time that you're doing those things. And I understand that, a nebulizer treatment without a ventilator adjustment, that sounds good in theory, but you could be giving a breathing treatment that prevents mechanical ventilation completely. Mm-hmm. So why would you give that away?
Yep. Now, one of the problems that I have is the so-called clarification could be misused by consultants. And
absolutely,
administrators that are beleaguered, they hire consultants, and consultants get a share of whatever cost savings. And they see RTs running around doing, quote, neb treatments. And they say, you can hire someone at less costs to do those same treatments. And the point is, that's very dangerous. I just don't know. It bothers me because now all of a sudden we're delegating some of our service to non-RTs. And where does it stop? And we'll talk more about that in a moment. How should RT departments respond to such a misguided approachment to our involving, as you pointed out, evolving scope of service?
Well, and I can tell you from, my exposure to leadership that it is very true that if finance and administration sees that there's a better way, they'll find it. If they think that that's the right thing to do, if it cuts cost at the bedside. So, if they think they can do it with less RTs, that's what they're going to try to do. So, but what they fail to understand is that respiratory therapy isn't a task. There's clinical reasoning to what we do. And when that clinical reasoning is removed, patient safety really suffers. Your length of stay increases, your readmission rates go up, costs go up, not down.
Right. Coincidentally, on November 11th, another one of those little timely coincidental, there was a post to the AARConnect that I shared with you, and you basically let me know what your thoughts were. It was in leadership management section. It was described an attempt at one South Carolina hospital to have respiratory therapists develop protocols to enable the PACU, post-anesthesia care unit nurses, to perform ventilator liberation and extubation. Question is, I think it really supports your argument. You don't want to give up what you really is in our domain. As the saying goes, what could go wrong?
Everything. For cancer. I mean, once again, like ventilator weaning is not a task. It requires interpretation of waveforms, evaluating lung mechanics, readiness. I mean, if a PACU nurse extubates a patient that's not ready, who is managing the crash? Who is going to have to fix that?
That's
who
right.
is responsible for competencies, for signing them off? I mean, it's not just a scope issue. It is a huge patient safety issue.
Absolutely. Absolutely. Well, it's been suggested by many influential RT thought leaders and backed by credible evidence that respiratory care services rendered under evidence-based, patient-centric, and RT-driven protocols deliver superior, cost-effective clinical outcomes, improved patient experience of care, and enhanced staff satisfaction. In your view, why does such approaches to care reduce the incidence of what we call low-value care that is ordered? We have to give it because it is ordered, but yet there's no clinical advantage. We're doing it because it's a task.
Right. Well, I mean, honestly, like protocol-based care is allowing therapists to work at the top of their scope. It's going to eliminate treating numbers. It's going to prevent stacking short-acting nebulizers on top of long-actings. You're practicing out of evidence-based medicine, not habit. And so that really changes things. And when a therapist can treat a patient, there's just nothing like it. I mean, that's where our impact is.
One of the points you raised in your earlier argument in LinkedIn was that even if we're not giving a treatment, we still see the patient because they're going home.
Yes.
And they're going to have continuing care needs. And the literature shows that even after optimum training, probably about 3/4 of patients misuse their inhaler.
Yes.
Okay, so that goes to your point. We're not doing anything to stop readmissions. In fact, we're trying to encourage them because we're not giving the patient the information they need to take care of their continuing care needs.
Right.
And
I think that is to me, that's where we can make the biggest impact, is the education that we provide and keeping the patient out of the hospital.
Yeah. It's not discharge planning, it's care transition. And that's what it is all about. Now, what would you say to those RTs when you talk about protocols? They say, hey, that sounds good, but it just won't happen here.
So which RTs are we talking? Are we talking from the bedside or the leadership?
I hate to say this, but both.
Yes. Okay. All right. Well, so from the bedside therapist, from that perspective, we complain a lot, and we have to stop doing that. We need to show our contribution. So, when we can, we need to bring solutions, not just problems. And, there are so many super smart people in departments that I think have a lot of great ideas if they will share them with leadership and offer their solutions. But on the flip side of that, on the leadership side of that, you have to engage your people to want to do that. You need to share information with them and be transparent about what the challenges are for you as a leader, for the hospital. Show them metrics and celebrate whenever they win. You just need to empower them, because honestly, consistency builds credibility, and credibility is what drives change. That's what gets resources.
I think you were pointing at a real important point right now. And the respiratory therapist, a clinical bedside clinician, has every right to get involved with how the healthcare delivery system is going to change. And as we move to value-based care, we're part of the solution, like you pointed out. Otherwise, we're going to be perceived as part of the problem. So Speak up, folks. That's what the message here. And coincidentally, what about our newest career option, the advanced practice provider? How could this delegating of these routine to non-RTs adversely impact this important development where we're now being looked at as physician extenders?
Yeah. So, you look at PAs and nurse practitioners and how they're currently utilized at the bedside. This is our moment, because, the APRT role can take shape exactly like PAs and nurse practitioners currently are. But if we delegate everything away, what physician is going to trust that? If a respiratory therapist isn't doing what respiratory therapists do, there's no reason to trust the APRT. So it really negates that role.
There is an association of pulmonary advanced practice providers for both nurse practitioners and physician assistants working in pulmonary medicine, and they don't delegate any of their issues. What does happen is physicians delegate to them complete control of the patient from the time they come into the office to the time they go home. So I think that's the message is that we want delegation from the physician. We don't want to delegate to non-respiratory therapists.
Exactly. Yep, I agree. And, there's a bottleneck that's happening right now in residencies. There's more medical students graduating than there are places to train them. So physicians are having to delegate to nurse practitioners and PAs. This is our time.
Mm-hmm. That's right. That's
right. We have a tremendous opportunity, and we're going to lose it if we disappear from the bedside.
Yeah, I hear you. Well, what about our colleagues who want to specialize outside of the acute care setting? They want to be in chronic disease management. And boy, you talk to people involved in pulmonary rehab, and their excitement is contagious because they know they can make a big impact on the quality of life of these patients. What options are available for those who want to go into chronic disease management?
Well, this is one of the things I think is one of the greatest opportunities that respiratory therapists have right now. People are living longer with chronic lung disease than they were before. Care is shifting outside of the hospital to the communities. And, that's one of the things that I think has been limiting to the RT role. That's one of the reasons that I hear that people are choosing nursing over respiratory, is just the opportunities outside of inpatient settings. And so this really makes us competitive with that. This gives respiratory therapy an opportunity to not just be needed inside the hospital.
Right. And in the hospital, not just in the intensive critical care units, as you pointed out so clearly in several of your posts on LinkedIn. I can understand it. We did kind of really learn a lot during the COVID pandemic. We lost a lot of people in the United States. We lost some of our own, who basically answered. But at the same time, it really showed that the respiratory therapist is indispensable in the critical care setting. And you pointed out in your editorial, we're also just as indispensable outside of critical care in the clinical areas that are not intensive at the bedside for the patient recovering from an exacerbation, for example, who's been transitioned out of critical care.
Yeah. I mean, honestly, I feel like we are more instrumental outside of the critical care setting. And I say that going back, I worked at the bedside during the pandemic, and I can tell you that, there were many patients that respiratory was able to keep off of the ventilator. And we did that through incentive spirometry, prone positioning, deep breathing and coughing. I mean, sometimes breathing treatments if they were necessary. I think there's really more opportunity to shine outside of critical care.
Mm-hmm. Probably more patients as well. Numerally more patients outside intensive care units. And that transition, the problem is you can't get this letdown. Well, I'm not in critical care, but yet, like you're saying, maybe we can stop them from transitioning back to intensive care. And there was a study done several years ago when I was involved with the AARC writing clinical practice guidelines that showed that when patients are removed from the intensive care unit prematurely and they bounce back, the mortality rate is like 75%.
Yes.
So once they come out of the intensive care unit, they're very fragile. They're very vulnerable. And at your point, that's where we can really show the value that we can bring.
Yeah. I think that, that is paramount to what we do. I think that I don't think that we're realizing our value fully there. Yeah. Critical care is glamorous. We know that. That's the fun thing to do. But our assessments and prevention, that's where we are very, very valuable.
Right. One of the nice things that you pointed out, again, I keep going back to your posts because they really generated a lot of the enthusiasm for me to want to do this interview, was that when the patients have a chronic condition, they're recovering from an exacerbation, they're not quite ready to go home, and their family is there, they're scared, and they're very concerned because no one likes to come into the hospital through the emergency room. And your point was, well, this is an opportunity to do our soft touch where we can actually build confidence, where we can alleviate fears of the unknown and take time to help these patients become more comfortable with what the role and responsibility is. And I just think that teaching, patient education and teaching in their language, not to dumb it down, but in their language, really has a much longer impact when they leave the hospital.
I would agree. I mean, there's so many things, diet and medication management, and even helping them figure out, how to get their medications. Some people have a lot of financial challenges, and there's opportunities there on the patient experience side for us to, help solve some of those problems. We can make an impact with families, and that's really making that connection with families and patients. I mean, that's incredible. I mean, we can offer so many things there.
Well, Carri, you've certainly provided us with credible insights and delivered a very well-founded and solid, from personal experience, argument about the dangers of delegating and at the same time, the opportunities of continuing your education with an advanced degree. Any final thoughts or words of wisdom to those skeptics that might be listening and say, yeah, it sounds good, but it's not for me?
Respiratory therapy is amazing, and I absolutely love this profession. But, staying relevant requires engagement. We cannot practice from the department. We have to get back to the bedside. We have to raise the bar. And we have to stop treating respiratory therapy as a stepping stone and return it to treating it as a destination career, because it is. If I could say something to bedside RTs, it's that your voice matters, your presence matters. And, to leadership, your team is your legacy, and listen to them, empower them and advocate for them. I feel like, they don't work for you, you work for them. So, to our whole profession, this is it. This is our moment. And I don't want us to miss it because we are way too important to become invisible.
Yeah, you're absolutely right. And I just want to summarize one last point and I have your thought on this. I came to this idea the other night. I always think about ideas that I can proselytize when I get on RTMatters. And I said, respiratory therapists have a unique personality. And I picked that up by listening to everybody's story about how they get into it, including my own. When we find, usually by accident or by happenstance, a place where we can flourish, in other words, we find ourselves in an issue, we get motivated to grow professionally in practice and in our voluntary engagement. In other words, we take advantage of an opportunity because, hey, I could do a good job here. Like respiratory therapy found me and I found respiratory. And that's a unique personality. And what you're basically arguing is why squander that? Take advantage of that no matter where you are in the continuum.
Yes. Be excited because we bring so much to the table, so much more than I think we even realize. And, I just don't want to see us miss this moment and keep giving things away, to other people to do. Because it's just, that's not what needs to happen. We are so important.
That's right. Somebody once said, and it's rather crude, he says, if you're not sitting at the table helping make the decisions, you're on the table and you're the feast. So you want to be sitting at the table. Okay. Well, that brings us to an end of another episode of RT Matters. I want to thank our guest. Carri, you've been just fantastic for your insight and for your conversation. And I just want to let our members know that we want to hear from you. Let us know what you think about this. And we might have Carri back to talk about more of the things that you tell us that we can't do that we'll argue that we can do. And well, also, if you need any additional information about any of the things that we discussed or decided, let us know and we'll do it. Now, in the meantime, go out and be the best possible RT you can be, because our patients deserve nothing less, as was stated several times here. And as highly trained licensed healthcare professionals, we too expect nothing less of our colleagues as well. So until next time, be kind to yourself and to others. And remember, respiratory therapists do indeed matter. So take care of yourself, be safe, and we look forward to having you back real soon.